So, Dr. Grisham, just to kick us off, we know most of us have a general idea and information about rare ovarian cancers, particularly low-grade serous, right? So, but what is it that we may not know about the type and progression of these particular subtypes that you would like to share with us as we kick off the session today?
Yeah, thanks. So yeah, there's really a large number of different types of ovarian cancer. And just talking about epithelial ovarian cancer, of course, the most common type is high-grade serous ovarian cancer, but then we have these rarer subtypes like low-grade serous ovarian cancer, clear cell ovarian cancer, endometrioid ovarian cancer, dedifferentiated, mesonephric-like, multiple different types. And those are just the epithelial types, of course. Then we also have subtypes like granulosa cell tumor. Um, but I think one way to start by differentiating ovarian cancer is also to split it up by those cancers that we believe truly develop from the ovary or fallopian tube, or those cancers that develop from endometriosis. So, we commonly group clear cell and endometrioid cancer as being ovarian cancers, when these cancers are truly cancers that developed from endometriosis in the majority of cases. And now that we do have better therapies for endometrial cancer and better understand the drivers of these individual diseases, I think we have to really start making an effort to try to differentiate those endometriosis-associated cancers from our cancers that truly originate in the ovary and fallopian tube. And I think in the coming years, there's going to be more of a push to try to differentiate those groups of cancers as we do start to develop more targeted therapies and more available options for our
Yeah.
patients.
That makes sense. Thank you. And so we also know that you led this phase 2 clinical trial that led to the accelerated approval of the first ever drug for low-grade serous ovarian cancer. Congratulations on that. So can you tell us more about the trial, its indications, primary patient population that are eligible to receive treatment, and anything additional that you would like to share?
Yeah, of course. Thank you. Yeah, I could talk about that for a long time. So, so just to start with, so low-grade serous ovarian cancer. So this accounts for a little less than 10% of cases of ovarian cancer. And historically, we think of low-grade serous ovarian cancer as being less responsive to chemotherapy. It has lower response rates than high-grade serous ovarian cancer has to chemotherapy. Now, that doesn't mean that chemotherapy doesn't work for all patients with low-grade serous ovarian cancer. There certainly are patients with that disease who respond to chemotherapy. But overall, the response rates are quite a bit lower to chemotherapy in our patients with low-grade serous ovarian cancer than in our patients with high-grade serous ovarian cancer. And over the past decade, we've really realized that low-grade serous ovarian cancer has a unique molecular profile when compared to high-grade serous ovarian cancer. In fact, we used to think of it as like a continuum, and we used to grade serous ovarian cancer as grade 1, 2, or 3. But that's now obsolete. We consider these to be two separate diseases, low-grade serous and high-grade serous ovarian cancer. And so patients with low-grade serous ovarian cancer, they rarely have disease that's driven by BRCA or HRD, homologous recombination deficiency. Instead, the most common alterations that we see in this disease are MAP kinase alterations. So that would most commonly be mutations in KRAS or BRAF or NF1. And these are somatic mutations, mutations that happen in the tumor itself. They're not hereditary mutations that would be found in the blood or every cell of the body. And so as we've come to understand that these alterations drive the development of this cancer, that of course has led to interest in how can we inhibit that pathway specifically. And so the initial studies in low-grade serous ovarian cancer primarily looked at single-agent MEK inhibitors, such as binimetinib, selumetinib, trametinib, which are single-agent oral MEK inhibitors, and initially did show promising results for patients with low-grade serous ovarian cancer, with response rates ranging from 15% to 25% with the use of these single-agent MEK inhibitors. And while that's better than what we generally see with chemotherapy, of course, it still leaves a lot of room there for improvement because we want better response rates than that. And also, these single-agent MEK inhibitors have quite a lot of toxicity. They can commonly cause significant rash, as well as GI side effects, edema, risk of congestive heart failure, and can be difficult to tolerate long-term. And so the idea of avutametinib and defactinib is that it's a combination therapy, that's pills that are given intermittently, so they have less toxicity, and that target the pathway from multiple different directions. And so avutametinib is a RAF-MEK clamp, so an oral targeted therapy. And defactinib is an oral FAK inhibitor. FAK is a pathway that can lead to cancer cells migrating, traveling far away in the body, adhering to different parts of the body and developing a blood supply. And FAK inhibitors try to inhibit all of that and also can help prevent drug resistance. And so the combination of avutometinib and defactinib are taken on an interesting dosing schedule. So the avutometinib is taken twice a week, 3 weeks on, 1 week off, and the defactinib is taken twice a day, 3 weeks on, 1 week off. So out of a 4-week cycle, patients take the drugs 3 weeks. And by doing that intermittent dosing, it seems to have decreased some of the toxicity that we generally see with MEK inhibitors, while also showing a very good response rate and progression-free survival. And so the RAMP 201 study is an international study that enrolled patients with recurrent low-grade serous ovarian cancer. And it initially randomized patients to either treatment with avutometinib by itself or avutometinib in combination with defactinib. And based on the initial analysis of that comparison, it was found that the combination of avutometinib with defactinib was more effective with similar toxicity. And so the decision was made to go forward with the combination and to not treat patients with avutometinib alone. And then the expansion cohorts from that study showed really, really promising results for our patients. So an overall response rate of 31%, specifically in the patients with a KRAS mutation, the response rate was 44%. And in those patients with a KRAS mutation, the median progression-free survival, meaning the amount of time that patients remained on treatment until they developed progression, was 22 months. And something that was also really remarkable was that amongst those patients who had a confirmed response, those responses were very long lasting. So the median duration of response was over 31 months. So patients that responded didn't just respond and then develop progression quickly after that. They had these long lasting responses. And so these were really unprecedented results and really promising results for our patients, especially those with a KRAS mutation. And so this study, this RAMP 201 study, led to accelerated FDA approval for the use of avutometinib and defactinib, specifically in patients with low-grade serous ovarian cancer who have recurrent disease and harbor a KRAS mutation. Now, patients that have a KRAS mutation with low-grade serous ovarian cancer, they tend to have a better prognosis, and they tend to have better response rates to MEK inhibitors and also to chemotherapy. And so although the response rate in the KRAS wild type patients, the patients that don't have a KRAS mutation, was lower in that study, they still responded also. The response rate was 17% there, and with a median progression-free survival of about a year. And so there's an ongoing phase 3 study, the RAMP 301 study, which is almost done with accrual. It's already completed accrual in the United States, few spots left internationally. Which is randomizing patients with recurrent low-grade serous ovarian cancer to treatment with avutometinib and defactinib versus standard of care therapy with chemotherapy or endocrine therapy. And so that study allows in all patients, both KRAS mutant and wild type. And hopefully that study could potentially lead to not only full approval of avutometinib and defactinib for women with recurrent low-grade serous ovarian cancer that have a KRAS mutation, but potentially also approval of this combination for all patients, regardless of mutation status, which is great because about a third of our patients with low-grade serous ovarian cancer have a KRAS mutation. So it'd be great to have this option available for all of our patients. So that study is ongoing and will hopefully be reporting out in 2026, depending on the interim analysis. But in the meantime, we now have this first ever approved drug for low-grade serous ovarian cancer based on this accelerated approval of avutometinib and defactinib, which is now available to patients with recurrent disease that have a KRAS mutation and can be prescribed by your physician.
Thank you, Dr. Grisham. I will stop here for just a second to ask our overcomers and friends watching, if you have any questions that you would like to ask Dr. Grisham directly, now is your opportunity. Feel free to ask her. Anyone? Okay, so I will go to a few questions that James had posted and shared with us. So basically, and James, I saw that you are here, so please feel free to add to the questions that I'm asking on your behalf to Dr. Grisham. So his first question was, given the low response rates to chemotherapy in LGSOC, what does the latest evidence say about shifting away from chemo as a standard post-surgical treatment?
Yeah, so, it's a really important question. We consider our standard of care for women with advanced ovarian cancer, whether it be low-grade or high-grade serous, to be chemotherapy after debulking surgery. And then in the case of low-grade serous ovarian cancer, letrozole maintenance after completion of the chemotherapy for patients with advanced disease. But people have been asking, if there's lower response rates to chemotherapy, can we just do letrozole after surgery in people with advanced disease, and would that be adequate? So this is a really important question that we don't have data to give an informed answer to. And so a international phase 3 study through the NRG set out to answer this question. And it enrolled more than 500 patients with stage 2, 3, or 4 newly diagnosed low-grade serous ovarian cancer. And after primary debulking surgery, randomized those patients to either 6 cycles of carboplatin and Taxol chemotherapy followed by letrozole, or after primary debulking surgery, letrozole maintenance alone. And so this was, there were doubts about if the study would be able to complete accrual, because it's always hard to find patients willing to volunteer their time for a clinical trial when the randomization options are both standard of care therapy. But we know we have a highly motivated, very scientific, very well-informed patient population here who were very, very willing to donate their time and participate in this study. And so the study completed accrual even quicker than projected. And has now completed accrual. And so now we just need to wait for the results of the study. And so we should have this important answer in the future. We don't know exactly when that will be. There is another interim analysis coming up in the next few months. But it will probably take longer than that to get the readout of that study. So hopefully within the next 12 to 18 months, we'll have some initial results from that study, because it's so important for us to be able to give our patients clear answers about that question, because chemotherapy, of course, does come with so many side effects. We don't want to be offering that to our patients unless we know that it's giving an actual benefit. But for right now, while we await the results of that study, we still don't have the answer to that question.
Thank you, Dr. Grisham. Moving on to the next question from James. He's asking, how are BRCA2 mutations, KRAS, G12D? You have to correct me if I'm not saying these right. Yeah, and NADK pathway activations shaping treatment strategies for LGSOC. Are targeted approaches like the MEK or the PARP inhibitors preferred in maintenance or recurrence?
Yeah, it can be tricky when a patient with low-grade serous ovarian cancer has a germline or somatic BRCA mutation, because we don't typically think of BRCA as being a driver of low-grade serous ovarian cancer. So when somebody is found to have with a diagnosis of low-grade serous ovarian cancer is found to have a BRCA mutation, the first question is always like, well, is that diagnosis correct? And so I would say that should generally prompt like a second opinion of the pathology, just to make sure that it truly is low-grade serous ovarian cancer and not high-grade serous ovarian cancer, or a combination of the two. And also, in addition to that, patients can have a BRCA mutation without it being the driver of their disease. And so, there's a certain prevalence of BRCA mutations just in the general population, and someone could be found to have a germline BRCA mutation and it not be the driver of their ovarian cancer. But generally, we don't consider low-grade serous ovarian cancer to be driven by BRCA mutations. But in the rare case where somebody with low-grade serous ovarian cancer is found to have a oncogenic BRCA mutation, not a variant of uncertain significance, it would be reasonable to use a PARP inhibitor in the first-line maintenance setting. But I'd say that's pretty rare that occurs. Regarding KRAS mutations, yes, so this is now a biomarker indication for a treatment. So for patients with recurrent disease who have a KRAS mutation, I would consider avutometinib and defactinib to now be a first-line option for those patients in the recurrent setting. And then for our patients who have a BRAF mutation, there is an approval not specifically for low-grade serous ovarian cancer, but for cancer in general. And when patients with low-grade serous ovarian cancer have a BRAF mutation, it's almost always a V600E BRAF mutation. And so there's a drug combination of a MEK inhibitor and a BRAF inhibitor, vemurafenib with trametinib. And this combination is approved for any patient with any type of cancer that has a V600E BRAF mutation. And so I'd say both for patients with recurrent low-grade serous ovarian cancer who have a KRAS mutation or a BRAF mutation, there are approved targeted therapies specifically for those indications. And given these approvals, it's so important that all of our patients are routinely having somatic tumor testing performed. And when I say that, so when someone is diagnosed with ovarian cancer, it's of course standard to have germline testing done to see if they have a hereditary cause for cancer, like a BRCA mutation, and that testing is usually done on blood or saliva or fingernails. But it's also important to have somatic tumor testing done, and that means testing done on the tumor itself. Now, there's certain types of platforms that use circulating tumor DNA from the blood to do the somatic testing, such as Tempus and other commercial providers, but I do not consider that to be adequate testing for patients with low-grade serous ovarian cancer because those tumors tend to be lower shedders in the blood. And so to do that somatic tumor testing, it really has to be done on the tumor itself. So archival tissue that's kept from the initial biopsy or surgery, that tissue can be sent to various commercial providers, be it Foundation, Caris. There's lots of different ones that different physicians use. And that is to see what mutations are specifically in the tumor. But you don't want to do blood-based testing and miss a KRAS mutation or a BRAF mutation that might have been identified on the tumor testing. So I think it's really important to make sure that the tumor is tested for those mutations.
Thank you, Dr. Grisham. He has a couple more questions. I'll come back to them in a second. I see a question in the chat. Basically, Meredith is asking that she just started chemo again for the first recurrence. She's asking if it doesn't work after 3 cycles, can my doctor prescribe the new drugs and will insurance cover it? Meredith, if you could provide a little more information on your disease state and type of ovarian cancer, I think that will help Dr. Grisham answer your question a little more in depth. And feel free to ask her directly if you're here.
Okay, hello, I'm sorry. I'm just getting to a quieter area. Can you hear me?
Yes, we can hear you.
Okay, great. So I had debulking and 3 cycles of chemo last summer, and I was doing well on the just letrozole until I did have a recurrence last month, and they started me on chemo again, but I'm doing just frontline again. And I had asked my doctor about the 2 new drugs, and she mentioned that we'll see how this goes with the 3 cycles of chemo and a new scan, and then I could be a candidate for the 2 new drugs. She had mentioned that the insurance will not cover them until they're approved.
Yeah. So Meredith, do you know if your tumor has a KRAS mutation?
She said that yes, it does.
Okay, great. And so here's the thing. It's so good that you're advocating for yourself because it is hard for doctors to keep up. There are new drugs FDA approved every week, and many, and I only treat gynecologic cancer. There's, many oncologists are treating lots of different types of cancer. And so it can be really hard to keep up with these approvals. But avutometinib and defactinib are now FDA approved for low-grade serous ovarian cancer that's recurrent and has a KRAS mutation. So yeah, they can be prescribed by your doctor with a prescription just the regular way. Don't have to be on a clinical trial if you have a KRAS mutation and have recurrent disease, like is your case. And so And it can be any type of KRAS mutation, G12C, G12D, any of them. It's not specific. But but it's really hard for doctors to know that because they're treating lots of different types of cancer. And this is, an approval for a rare disease. And so it can take a long time for that information to percolate through the whole country. And so that's so great for you to be informed and to be advocating for yourself. But yes, so these drugs are an oral therapy. And so the way that they are prescribed is that they're made by a company called Veristem. And so the prescriber goes to the doctor goes to that company's website and they can print out a form that allows them to prescribe the medications. The reason they do it that way is because these medicines are very expensive. And so they have a built-in a system to see if patients that have a high copay can get free drug from the company. And so the medicines are prescribed to a kind of pharmacy called a specialty pharmacy. And then there's a program in place to try to provide free drug to people that have a high copay. And so these drugs are now available by prescription. But it just happened a couple months ago, so it's still very new information. So it's great for you to be informed and to help your doctor learn this information.
So thank you for that info. Am I eligible even though I've just had a round of chemo, or should
Well,
I?
you want to talk to your doctor, of course, because if the chemo is working, then they would be very reasonable to stay on the chemotherapy. And so since you've just started it, you could always reassess after like cycle 3 if things are going okay, and if the chemo's
Mhm.
working, very reasonable to stay on that. But if it's not helping you, then I think it would be reasonable to consider changing, in conjunction with your doctor, of course.
Okay, yeah, because I mean, if I had known that it was available, I probably would have tried to go that route because don't see myself working, like just with the chemo side effects and all of that. But
Maybe do a
um,
scan after cycle 2.
okay,
Do it sooner. But yeah, I think so talk to your doctor about this because it is approved. But this is just brand new. It just happened. And
okay,
so it's understandable that it would take your doctor time to have that information.
okay. So the best advice for her would be to go to that website, like you were saying,
Yeah,
and
on the
okay.
website for the name of the company that makes the drugs is called Veristem, and they have information for prescribers there that can tell them like how to prescribe the medication because it is tricky too. There's so many different oral therapies now, and they go to special types of pharmacies called specialty pharmacies. That's where like
Hmm.
PARP inhibitors and Lenvima, other types of oral drugs go. And there's only certain pharmacies that they can go to, which is it's a lot more complicated than it used to be. But they have information on the website that tells them how to do it.
Okay, all right. Thank you so much for the information. I really appreciate it.
Of course, good luck.
Thank you.
Thank you. So we have another question in the chat, Dr. Grisham. The question is that given the unique molecular profile of low-grade serous ovarian cancer, including frequent MAPK pathway alterations, how do you currently approach treatment sequencing, particularly in choosing between endocrine therapy, MEK inhibitors, and chemo? And for which indication would you start systemic therapy after primary cytoreduction?
Yeah, great questions. And I should mention, in terms of recurrent disease, in addition to these indications for patients with a KRAS mutation or a V600E BRAF mutation, which are both mutations in the DNA, which would be seen on a next generation sequencing report on a study of the DNA that's been extracted from the tumor. There are also new antigen drug conjugates, which are options not only for our patients with high-grade serous ovarian cancer, but for patients with any type of ovarian cancer, which express these proteins. And so antigen drug conjugates are basically a antibody that binds to these ADCs have an antibody that binds to a protein on the cancer cells, antibody drug conjugates, and then it has a warhead that it specifically puts into the cancer cells or into the surrounding area around the cancer cells. I'm sorry, I meant antibody drug conjugates. And these drugs, there's two newly approved drugs that apply to our patients with ovarian cancer: mirvetuximab, which targets folate receptor alpha, and famtrastuzumab deruxtecan, which targets HER2. And so both of these drugs are drugs that are given IV and then specifically bind to these proteins on cancer cells and give this directed cytotoxic therapy to those cells. And so about 40% of patients with low-grade serous ovarian cancer will have high levels of folate receptor alpha on their cancer cells. And then we don't quite yet know what percentage of patients with low-grade serous ovarian cancer will overexpress HER2, but a certain percentage of patients with low-grade serous ovarian cancer will also overexpress HER2. And so it's good to check to see if your tumor overexpresses these proteins and makes you a potential candidate for these newer ADCs as well. And so the way to do that is that your doctor, depending on how their health system works, sometimes just internally, they can have their pathology department cut some extra slides and check the immunohistochemistry, the IHC, to see if the tumor overexpresses HER2 or folate receptor alpha. Or other times they send it out to an outside provider, such as Caris or other providers, which can do this IHC testing on the tumor. And so it's really, and then that's something that we weren't doing just 1 or 2 years ago. And so for people that are not newly diagnosed, it's important to now go back and do that additional testing on their tumor, because you want to know all of the drugs that you're potentially eligible for. So in addition to the genetic tumor testing, you also want to do this immunohistochemistry IHC testing on the tumor, in particular to look for folate receptor alpha and HER2. So when thinking about sequencing, in terms of first-line therapy, after initial surgery, our options are still chemotherapy followed by letrozole or letrozole for patients with advanced disease. We do have a clinical trial ongoing looking at using this newer combination of avutometinib and defactinib in combination with letrozole for patients with advanced stage disease who are not candidates for primary debulking surgery, or in the adjuvant setting if they have a suboptimal debulking. But that's still in a clinical trial setting. And so we have to see what the results of that study are before moving that treatment to the first line setting. But then for recurrent disease, I'd say for patients who have a KRAS mutation, I would prioritize avutometinib and defactinib. For patients that have a BRAF mutation, I would prioritize the MEK-RAF inhibitor combination. And then for patients that have overexpression of HER2 or folate receptor alpha and do not have one of these mutations, I would prioritize one of these ADC treatments. And then for patients that don't have any of those 4 biomarkers, we have options of chemotherapy or endocrine therapy. And oftentimes that choice depends on various factors specific to the person and how long it's been since their initial treatment and what their burden of disease is and what their existing side effects from their prior treatment are and such. But now it is great that we have multiple different targeted therapies that are options.
Thank you, Dr. Grisham. We do have another question in the chat. And Michelle is asking, please comment on MEK inhibitors for high-grade mesophrenic, like with KRAS mutations.
Yeah, so mesonephric and mesonephric-like cancer are being increasingly diagnosed as pathologists come to better understand this diagnosis. And so mesonephric cancer arises from the cervix, while mesonephric-like cancer arises from other areas, most commonly the lining of the uterus, the ovary, or endometriosis. And so, but both mesonephric and mesonephric-like cancer very commonly harbor somatic KRAS mutations. In fact, they're even more common in these cancers than they are in low-grade serous ovarian cancer. In low-grade serous ovarian cancer, about 33% of patients will have a KRAS mutation, while in mesonephric or mesonephric-like cancer, more than 80% of patients will have a KRAS mutation. And mesonephric and mesonephric-like cancer traditionally are also less responsive to chemotherapy and more likely to metastasize, and unfortunately, oftentimes metastasize to the lung. And so because of this, we of course were interested in this active drug combination and whether it could potentially be an option for patients with mesonephric or mesonephric-like cancer. And so we actually opened a study here at Memorial Sloan Kettering Cancer Center where I work, specifically treating patients with mesonephric or mesonephric-like cancer with avutametinib and defactinib. And that study has shown very promising results. So the initial results of that study I presented at SGO earlier this year, which showed that the response rate exceeded what was necessary to proceed from stage 1 to stage 2 of that study. And the final results of that study will be presented at IGCS in the fall in South Africa. Those results are embargoed, but I can tell you based on the initial results that we presented that the combination is looking very active for patients with this disease. And then the hope now that this is an approved drug combination would be that, based on these promising results seen in mesonephric and mesonephric-like cancer, this might soon be an available off-label option for patients with that disease.
Thank you, Dr. Grisham. I'll go back to the couple of questions that James had. So the third question that he was asking is, estrogen blocking therapies are important in ER-positive low-grade serous, but can cause or worsen menopausal symptoms such as depression and emotional changes. So how do you recommend managing this while maintaining treatment effectiveness?
Yeah, it's really hard. And so I'd say with aromatase inhibitors in general, the symptoms are sometimes worse the first 3 months. And so if possible, we do try to support our patients at least through 3 months of treatment with an aromatase inhibitor before considering change in therapy. Now, sometimes people tolerate one drug better than others. So sometimes just switching from like letrozole to anastrozole can help with the symptoms, or if necessary, changing to a different class of medicine, like changing to exemestane or fulvestrant. But in terms of managing those side effects, which can include, of course, hot flashes, joint pains, joint stiffness, and then the risk of osteopenia, osteoporosis, we find that the joint stiffness is best overcome with frequent activity and exercise. So it can be helpful for people to use a standing desk or a walking pad, or being able to at least get up once an hour to move and stretch, so that our joints don't get so stiff. Our colleagues in the breast world commonly recommend tart cherry for the joint pains, and so I recommend that to my patients as well to try as a supplement. And then for the hot flashes, we do have more non-hormonal options now for treatment of hot flashes. Traditionally, we generally used venlafaxine or gabapentin. Now, more recently, there's the approval of Veoza for hot flashes, which can be helpful. And then there's also several over-the-counter remedies that in some cases can be helpful. So it is good that we're getting more options than we used to have, but these side effects are very difficult. And so it's good to try to use as many different options as possible to try to overcome these side effects, since this is a drug that's oftentimes taken long-term for many years. And so you want to be able to have the best quality of life possible.
Thank you, Dr. Grisham. I'll pause for a second if anyone has a question that you would like to ask Dr. Grisham directly. Otherwise, I'll go to my next. Please feel free to ask any questions and it doesn't have to be low-grade serous specific either. It can be anything related to your treatment, diagnosis, and survivorship, side effects, anything that you would like to ask Dr. Grisham. Okay. And if you have any questions while I go to the next one, you can always put it in the chat and we will get it addressed. So the next question is, are there promising immunotherapy options, such as boosting T cells or NK cells for patients with PD-L1 expression or HRD positive low-grade serous?
Yeah, so in low-grade serous ovarian cancer, we generally think of that as a low tumor mutation burden tumor, which has led us to generally not favor immunotherapy options. So we don't use PD-L1 currently as a biomarker for any type of ovarian cancer. It is in certain other tumor types, such as cervical cancer. Now, interestingly, in high-grade serous ovarian cancer, there's a study that we don't yet have the official report from, only a press release, but that looked at the combination of paclitaxel with bevacizumab and pembrolizumab and showed improvement in progression-free survival with that combination versus Taxol and bevacizumab alone. And then also specifically, they're saying an improvement in overall survival in the PD-L1 positive patients, but that's based just on a press release. The results of that study have not been formally presented or published yet, but we await that presentation to get more information about that study. As we've seen kind of a trend towards some improvement in PFS and response rates in PD-L1 positive patients with high-grade serous ovarian cancer with use of immunotherapy. But thus far in the prior studies that have been done in the upfront and recurrent setting, the addition of immunotherapy doesn't seem to have added considerable response rates or shown improvement in overall survival in any of these other prior studies. And so in low-grade serous ovarian cancer, which we would generally consider to be a less immunogenic environment, we generally don't favor immunotherapy options. There is an ongoing clinical trial in Europe that is looking at immunotherapy in low-grade serous ovarian cancer. But for right now, if I had a patient with low-grade serous ovarian cancer that was PD-L1 positive, I wouldn't generally go to immunotherapy very quickly because I would consider it to be not very active.
Okay. Thank you, Dr. Grisham. And James, if you have any follow-up questions, please feel free to ask Dr. Grisham directly or put in the chat. Dr. Grisham, this question is from Lilia, and this is more of a generic question. So her question is, what current treatments or clinical trials are available for recurrence in stage 3 ovarian cancer with a BRCA gene mutation? And how can we, as patients, stay informed about existing clinical trials? This is from Lilia.
Yeah. So, in the recurrent setting, while BRCA mutation can help patients to be more sensitive to platinum chemotherapy, generally we use PARP inhibitors less than we used to. And so for patients that have a BRCA mutation, it's recommended that everybody with a BRCA mutation receive a PARP inhibitor as a maintenance therapy if they have stage 3 or 4 disease after their initial chemotherapy. And then we used to also use PARP inhibitors as a maintenance therapy for patients after platinum-sensitive recurrence treated with chemotherapy with a complete or partial response, or for patients with a BRCA mutation with recurrent disease as a treatment therapy. But those approvals were subsequently voluntarily revoked or changed based on long-term study data showing a numerical decrease in overall survival. And so right now, PARP inhibitors are specifically prioritized for those patients with newly diagnosed ovarian cancer that has a BRCA mutation to be taken as a maintenance therapy after their initial chemo. And then also can be used in the recurrent setting as a maintenance therapy following complete or partial response to chemotherapy, preferably in patients that have not previously progressed on a PARP inhibitor. So in terms of clinical trials, I would say that in the recurrent setting, oftentimes the BRCA is not going to be the defining characteristic. It would more be a clinical trial for patients with recurrent disease. And then if it has a biomarker, might be testing for certain types of proteins, like for ADCs, or may not require a biomarker for that study. But each clinical trial is different. But there are, multiple different clinical trials opening up right now for new options for ADCs for patients with ovarian cancer, looking at both different protein targets and also using different warheads, different cytotoxic drugs that are attached to them. So currently, there are ADCs in development that target folate receptor alpha, that target other markers that can be found on cancer cells, and so that can be an inclusion criteria for some of them. But always best to talk to your doctor about what studies they might have available, and then also clinicaltrials.gov. If you search for your geographic location, and ovarian cancer can see what clinical trials are available in your area.
I would also add to that, Dr. Grisham, is on our website. We do have a clinical trials finder, which is focused on ovarian cancer only. So you don't have to get lost in the sea of clinical trials, because it's a humongous rich data website, right? But if you, so we took it is of course fathered by clinicaltrials.gov, but we have filtered it down to ovarian trials only. So you can search by investigator, you can search by zip code, you can search by all the smart searches that we typically do these days. For our overcomers watching, you can go to our website, and under our programs, you will see the clinical trials as a tab. If you open it, you will be able to search by clinical trial. On our website by your disease state and whatever else you would like to input to get to the trials that you want to get to. And we also have a clinical trial specialist who is there to answer any questions that you may have after you have done the research on our website. So I think the last question from James was that what are the best practices for monitoring recurrence in low-grade serous, and are there specific symptoms, blood markers, or imaging schedules you recommend for early detection?
Yeah, so CA-125 can be less of a marker in low-grade serous than it is in high-grade serous. So I generally recommend that women with low-grade serous ovarian cancer not be followed by CA-125 alone. There are prior publications by Amanda Fader at Johns Hopkins and others showing that the rate of CA-125 elevation is less, and then for more patients, it's not a biomarker at all. And so, the individual choice of imaging modality would depend on an individual patient and their stage and such. But I'd say generally imaging is done every 3 to 6 months in conjunction with blood work in order to monitor for recurrence. And I usually use CT, or if a patient had fertility sparing surgery and still has an ovary in place, we use ultrasound. But I'd say that the biggest message there is I don't think, for most patients who initially had advanced stage disease, it's not appropriate to follow with CA-125 alone, like imaging is necessary. I use CT of chest, abdomen, and pelvis.
Thank you. I will move on to the next question. Okay, there's a question from April. I'll put that down first. So she's asking, next week I start on Keytruda, Avastin, and cytoxan for a recurrence of endometrial carcinoma, high grade with mucinous differentiation. ER positive, progesterone receptor, PAX8. You can read this, Dr. Grisham. I think you're reading with me.
Yeah.
So what are your thoughts on this combination for recurring high-grade ovarian cancer?
Yeah, so I think this is probably an endometrioid ovarian cancer as opposed to an endometrial cancer, based on your description. And so, so endometrioid ovarian cancer is in many cases more similar to endometrial cancer than it is to high-grade serous ovarian cancer, because it oftentimes develops from endometriosis. And so there's a combination that's NCCN compendium listed of bevacizumab with oral Cytoxan and pembrolizumab.
One second, Dr. Grisham. If you are not speaking, if you could put yourself on mute. Thank you so much.
And so,
go ahead, sorry.
That's great, fine. So that combination is specifically NCCN listed for ovarian cancer based on a phase 2 single-arm study that showed a promising response rate of about 44% for this combination in largely platinum-resistant patients with recurrent ovarian cancer. Now, I would say that there have been questions about whether that combination is being primarily driven by the efficacy of the bevacizumab and the oral Cytoxan and how much the pembrolizumab is adding to it. We don't know because they haven't, just the bev and Cytoxan without pembro hasn't been compared to the triplet. But I think the situation here that April described of an endometriosis-associated tumor is a tumor where it makes a lot of sense to use that combination, since this is closer to an endometrial cancer than an ovarian cancer. So, I would say that is a NCCN compendium listed combination. The phase 2 study did show a very good response rate. And so I think it's a very reasonable option. Of course, with pembrolizumab and immunotherapy, that does come with additional risks in anybody that has a history of autoimmune disease like lupus or rheumatoid arthritis. Those things can become worse, but in general, for most of our patients, is well tolerated.
Thank you, Dr. Grisham. Friends, we are about 13 minutes away from our close time. So if you have any remaining questions, please feel free to ask Dr. Grisham directly. This is your chance. She's super friendly, and or put in the chat when we'll grab it for you. So I'll move on to the couple of remaining questions, Dr. Grisham, that I have. So in terms of potential side effects for all the treatments that especially the new FDA approval that just come through. So what should our overcomers know about the report and also the side effects, and also what our overcomers should know about the reportable statistics on the progression-free survival? I think you briefly mentioned it in the beginning, but just to rehash our memory. And it seems like the overall survival is still immature data to report. Is that appropriate?
Still immature,
correct?
Yeah. Okay. Luckily, many of our patients are still alive, which is what we want. So yeah, hopefully it's gonna take a really long time to get overall survival data from the RAMP 201 and RAMP 301 studies, but just still very immature, which is good in this setting. But yeah, so the progression-free survival with avutometinib and defactinib for patients with a KRAS mutation was 22 months. And for those patients without a KRAS mutation was about a year. And the response rate was 44%. That's a confirmed response rate, meaning that it had a duration of at least 2 scans. 44% for those patients with a KRAS mutation, and 17% for those people without a KRAS mutation, what we call KRAS wild type. Now the side effects, so yes, side effects are very important, and we want to do everything we can to try to prevent side effects when possible. So with avutometinib and defactinib, the side effects most commonly occur starting with cycle 1 that patients are going to have. And these can include ocular changes, so vision changes, including blurred vision or change in how our patients see different types of textures. And that can be from fluid accumulation in the eye. So it's essential that before starting these medicines, patients see an ophthalmologist for ophtho-clearance, and then they should be monitored by an ophthalmologist while on treatment with these drugs. And then patients can also develop an acneiform rash. Now, this is quite common with treatment with any type of MEK inhibitor, and it most commonly happens on the face and upper chest. But we've learned through many years of using MEK inhibitors that it helps prevent this rash from getting worse if we start with prophylaxis from the very beginning. And so I recommend that all my patients that are starting on a MEK inhibitor or starting on avutometinib, that they use a prophylactic antibiotic such as minocycline or doxycycline for at least their first 4 cycles, so first 4 months of treatment, but usually we continue it indefinitely, and that helps to prevent the rash. And these rashes also come out more with sun exposure, and so it's important to use good sun protection like hat, long sleeves, SPF to try to prevent too much sun exposure, because it's always the sun exposed areas that get the worst rash with MEK inhibitors. Other side effects can include GI side effects like diarrhea or nausea, and then it can also cause somewhat of an atypical peripheral edema, where people can get swelling not only in their feet, but also in their hands. When people get that swelling, we treat it with Lasix to try to bring down the fluid retention. But I find that if my patients use the skin prophylaxis, they're much less likely to get a severe rash. And luckily, with the avutometinib and defactinib, since it has this intermittent dosing where the avutometinib is only taken twice a week, and where you don't take any medicines the 4th week out of each month, usually the rash does not build up and become as significant as it does with a continuous MEK inhibitor that's taken every day. And then if needed, of course, you can always do a dose reduction of the avutometinib and or defactinib. Though I would say that I encourage patients that are starting these medicines to start at the full dose, the standard dose, because that is the most effective dose. So as part of the RAMP 201 study, there was a dose optimization cohort which used half dose of avutametinib, and the response rate was considerably lower in that group. And so I think dose, especially for these drugs that actually cause cancer shrinkage, I think dose does matter. And so I would encourage starting at the fuller dose. And so for these other ADCs that I mentioned, like trastuzumab deruxtecan and mirvetuximab, they of course have their own side effects also. And so with trastuzumab deruxtecan, the drug that targets HER2, that one can cause a risk of congestive heart failure. So patients need to have an echocardiogram done before they start treatment and then monitored while they're on treatment, similar to what is done with other chemotherapies like Doxil that can hurt the heart. It can also cause fatigue, decreased cell counts, and then also about a 10% risk of pneumonitis, inflammation of the lung. So if someone is on trastuzumab deruxtecan and they start to develop shortness of breath or cough, they should be urgently evaluated for pneumonitis, which can be diagnosed via chest X-ray or CT scan. And then for that other drug, that mirvetuximab, which targets folate receptor alpha, that one's side effects can include risk of neuropathy, hair thinning, decreased cell counts, fatigue. And then its kind of special side effect is that it can also cause ocular toxicity, but this drug can cause keratitis. And so to help prevent that, patients need to be seen by an ophthalmologist before they start that treatment, and then every 6 weeks while on treatment with that drug. And they also have to use prophylactic eye drops, both a steroid eye drop and a hydrating eye drop, to help prevent that ocular toxicity from occurring. And so unfortunately, each of these drugs have their own side effects. But now as we develop these newer drugs, much more commonly, we do try to, at the same time, in parallel, develop those strategies that will help to reduce or mitigate toxicity, so that hopefully our patients can have the best quality of life possible on these strong drugs.
Thank you, Dr. Grisham. There is we are running short on like 5 minutes left, but there is a question from Bijoy. It's in the chat. If you would like to read, and because there's a lot of information in there, or let me know if you want me to.
Yeah, so I would say if pathology diagnosis can be a little tricky. So it's interesting that this was called a mesonephric-like ovarian cancer, and it's KRAS wild type. It is ERPR negative, which would in part support that. But so I would say that the standard treatment here, given that it's BRCA and HR negative, KRAS negative, ERPR negative. So I would recommend chemotherapy with or without Avastin in this case. So carboplatin and paclitaxel, with or without bevacizumab added in, depending on independent risk factors for bevacizumab, such as risk for bowel perforation or poor wound healing. But in this case, if there's no contraindication to bevacizumab, I would generally recommend carboplatin and Taxol with bevacizumab added in starting at cycle 2 and then continued as a maintenance treatment for a year thereafter.
Thank you, Dr. Grisham. I see. One second. I see that James has written a very wonderful note for you. He's saying, my wife wanted to say thank you. We are sitting in the hospital after debulking surgery, listening to this. Your insight and knowledge is awesome. So thank you, Dr. Grisham, for spending all your time and your invaluable knowledge and insights with us. We appreciate you so much. Just a follow up on what you just responded to, Bijoy. He's saying that she's ER/PR positive, 8 cycles of carbo, and bowel resection has been done. So,
okay.
Yeah.
In that setting, bowel resection is not necessarily a contraindication to bevacizumab. So the options, I'm sorry, I missed that 8 cycles pre-op. So, options would include to do, presumably, I don't know what the response was to was there shrinkage with the initial carbotaxol that led to there now being an interval debulking after the 8 cycles? Yes, okay. So then I would still do additional carbotaxol afterwards, for 2 to 3 cycles, and then potentially add in Avastin if the surgical team feels like it's safe. But after a bowel resection, you can oftentimes add that in at cycle 3. and then continue as a maintenance therapy.
Okay. I will move on to I think we have time for only one question. So, you mentioned the RAMP 301 study. So this was submitted by one of our overcomers. She's asking, is there a possibility of expanding the drug combination? I think you alluded to that in the beginning, but this drug combination to the treatment of low-grade serous, regardless of the KRAS mutation status. And also, could this drug combination be used in other gynecologic cancers that are driven by the MAPK pathway mutations?
Yeah, for sure. So that is the goal of the phase 3 study, is hopefully it will allow an indication for all comers. We have to see, of course, what the results of that study are. But if they show that the response rate and progression, well, the primary endpoint is progression-free survival. So if it shows that the progression-free survival is better than standard of care therapy, because it's a randomized study, for the KRAS wild type patients, then hopefully this will lead to approval for all patients. The phase 2 study that led to accelerated approval was a single arm study. It wasn't randomized. And so that's why it's somewhat of a limited approval based on that study. But certainly the goal of this phase 3 study is to, if it's positive, to get that approval for all patients. And then, yes, definitely, we are looking at these drugs in other diseases. And so we have this study in mesonephric and mesonephric-like cancer. We're also studying these drugs in the neoadjuvant setting for low-grade serous ovarian cancer, and there's ongoing studies going in pancreatic cancer and lung cancer for use of these drugs as well.
Thank you. And the last question, I think you won't take long on this one. So the statistically low-grade serous affects younger patients. So what guidance would you share with younger women diagnosed with this subtype in advocating for themselves through the treatment process and beyond?
Yeah, and it's so hard because low-grade serous ovarian cancer has a younger median age of diagnosis on average, but oftentimes that's because our patients are diagnosed either at a very young age, like in their 20s or 30s, or at more the average age for ovarian cancer in their 60s. And unfortunately, it's our younger patient population that's less likely to have a KRAS mutation and is more likely to have aggressive disease. And so our patients that are diagnosed at an older age are more likely to have hormonally responsive disease and more indolent disease. And sometimes physicians, they think of low-grade serous ovarian cancer as like an indolent, slow-growing disease, which it is for some people, but not for everybody. And so I think especially for our younger patients, it's important that their disease course be closely monitored, especially for those first couple years after completion of initial surgery and chemotherapy, but definitely monitor with routine imaging, every 3 to 6 months. And so I think it's so important, especially that our young patients advocate to make sure that they're still getting the same type of aggressive care that a patient with high-grade serous would.
Thank you, Dr. Grisham, and thank you, everyone, all our overcomers, for joining us for this session of OC360 Live today. Thank you, and brilliant questions. And Dr. Grisham, thank you so much for your time and taking all of the questions of our overcomers and answering them in such details. We will post this video, edited version, so that more of our overcomers and family members are able to watch it post-production as well. So thank you all for joining us, and we'll be back with the next episode of O360 Live very soon. Until then, you keep inspiring and keep overcoming. Thank you. And thank you, Dr. Grisham. Thank you, and bye. Bye.